All right, welcome everyone to the EKG case for the week of July 23rd, 2012. This week's case is a little bit different from others. First of all, it might be a little bit longer than most, but it's a really important topic. And the reason I'm putting this case on is not because it was a recently interesting case that I saw, but actually because of a very, very important article that was published just within the past few days in print in Journal of the American College of Cardiology. And so I pulled a slightly older case just to highlight what we're going to talk about. So here's the case that we'll briefly discuss and lead us into a longer discussion. This is an 81-year-old woman that presents to the emergency department complaining of shortness of breath and diaphoresis. Now, I'm sure most everybody out there knows that given that this is an elderly woman, she's got two risk factors for atypical or non-painful type of presentation for ACS. She's, first of all, elderly, and secondly, she's a she. So 2 out of the 3 risk factors for atypical presentation. The other one is diabetes, by the way, and she might have diabetes. So we're going to take this seriously even without the chest pain. Looking at the 12-lead EKG, what we see is a wide QRS complex. We also notice that there's somewhat of a leftward axis. In leads V1 through V3, we see a little R deep S wave. And finally, the one other thing to point out is that in the lateral leads, 1, AVL, V5, V6, you'll notice that there are no Q waves at all. You're not allowed to have any Q waves with this condition. This is a left bundle branch block pattern. All right, so with the left bundle branch block pattern in those lateral leads, you have just monophasic R waves, or in other words, I guess more easily said, there should be no Q waves in those lateral leads. So what she's got is a left bundle branch block pattern. Now, we don't know whether this is new or old. If we found out that this was a new left bundle branch block pattern, given her concerning anginal type of symptoms, we would, even without the pain, again, this is an anginal equivalent in an elderly woman, we would say that this is qualifying for going right to the cath lab or for a dose of TPA because she has a new or presumed new left bundle branch block pattern. But if we knew that this were an old left bundle branch block pattern, there's something else on this 12-lead EKG which nails the diagnosis of acute MI and still justifies this patient going to the cath lab. So let's talk a little bit about left bundle branch block pattern and ACS. Probably most everyone out there, including myself, learned that when a patient has a left bundle, you really can't tell anything about whether there's ischemia. And a lot of the folks that taught me electrocardiography initially would say that, well, there's a left bundle, so don't even bother trying to read ischemia. Well, what we now know is that there are some very important things that indicate that patients with left bundle can be diagnosed with acute MI. So let's back up for just a moment and ask a simple question. Who needs emergent reperfusion when they present with anginal symptoms or anginal equivalent type of symptoms? In other words, who needs TPA or immediate lytics? Well, first of all, a person has to have some concerning symptoms. Then they have to have a diagnostic EKG. There are 3 EKG findings that are considered diagnostic of a STEMI, essentially STEMI or a STEMI equivalent. First of all, the one that everyone knows, if you have ST elevation in 2 contiguous leads, at least 1 millimeter, or it could be posterior STEMI, then that patient needs to get TPA or go right to the cath lab. Now, some of the older criteria said maybe you need to have 2 millimeters in certain leads, but I think most guidelines now just make it as simple to remember 1 millimeter in any 2 contiguous leads, whether we're talking about limb leads or precordial leads. That's in most of the guidelines. The second criteria that we've all learned is if somebody has a new or presumably new left bundle branch block pattern with concerning symptoms, then that qualifies for TPA or an immediate trip to the cath lab. And that's the first thing that this article talked about. There's increasing literature that says that a new left bundle branch block pattern does not equal acute MI. In fact, the original data upon which the guidelines were created stating that new left bundle equals acute MI equals lytics or cath lab were really not, the literature really was not that good, and we now have better literature saying that a new left bundle branch block pattern or presumed new left bundle is no more likely to rule in than a person with a known old left bundle, which is no more likely to rule in than a person with no left bundle at all. So the presence of simply a new left bundle really does not equal acute MI. And here's some of the articles that have been recently published. Chang, American Journal of Emergency Medicine, Contos, American Heart Journal, 2011. These are some very recent articles. Jane, American Journal of Cardiology, 2011. And then just within the past couple of weeks, Meta, published in Journal of Electrocardiology, my favorite journal. This is a journal that I use as bedtime reading. Journal of Electrocardiology. And then the article, we'll move forward to the article that just came out a few days ago, which really prompted this discussion in the first place. This is a really nice review article published in the main journal of the cardiologist, the most high-profile cardiology journal in the world, Journal of the American College of Cardiology. A very nice review article that talks about left bundle branch block pattern, where the original thought that left bundle equals MI came from, some of the new data that now says that this is probably not true, and also it talks about a few other things. It's a very, very nice read for any, not only cardiologists, hopefully they will read it, but for any emergency physician or any other type of acute care provider who might be in the scenario of dealing with chest pain or anginal equivalent patients presenting with a new left bundle. Very, very important article. All right, so let's move forward. The other criteria, which generally we now know or use as an indication for emergent reperfusion, is if a patient has a left bundle, new or old, who cares, but they have any one of the Scarbosa criteria. Now, what are the Scarbosa criteria? Many of you probably know these. We'll just quickly review this. Back in 1996, a cardiologist by the name of Elena Scarbosa put a bunch of cases and articles together and data together and came up with criteria that we now refer to by her name, Scarbosa criteria. And she said that if a patient has a left bundle, even if it's old, if a patient has a left bundle branch block pattern and that patient has ST segment elevation in any lead which is pointing in the same direction as the QRS, at least a millimeter elevated in the same direction, then that patient's having an MI. It's a STEMI equivalent. Take him to the cath lab or give him thrombolytics. And that had more than 90% accuracy at predicting the acute MI. We'll call that Scarbosa criteria A. Scarbosa criteria B, the second thing she described, was that if a patient has ST segment depression, which is more than a millimeter in V1, V2, or V3. Now recall that, and I'll show you this in just a moment, a normal patient with a left bundle in V1, V2, V3 has QRS complexes that point downward. So again, if the ST segment is pointing in the same direction as the QRS complex in V1, V2, or V3, then that, with greater than 90% accuracy, predicted that that patient was having an acute MI with their left bundle. I'll show you examples of these in just a moment. And then Scarbosa criteria C, or what I call Scarbosa C, if the patient has ST elevation which is in the opposite direction of the QRS, normally that's good, but if it's more than 5 millimeters in the opposite direction, that's too much. All right, so more than 5 millimeters of ST elevation in the opposite direction, she said that's too much. And that was found to have an accuracy. It had lower specificity and lower accuracy, maybe 50 or 60%, as I recall, but lower specificity for ruling in for an MI. But that was the third criteria that she described. Based on the data that's coming out, more and more of us are really believing that Scarbosa A and Scarbosa B are very useful. What if somebody has Scarbosa C? Well, because it has lower specificity, most people are not automatically taking these patients to the cath lab or automatically giving lytics to these patients. And that Journal of American College of Cardiology article also suggested this concept that if a patient has Scarbosa C, they really have to have compelling symptoms before you use Scarbosa C. Scarbosa A and B, that's almost a no-brainer. Of course, they should be having some symptoms as well, but that doesn't require much thought. If somebody's got Scarbosa C, you might have to think about it just a little bit more. So And these are just a couple of articles. There have been a bunch of articles that have supported the Scarbosa criteria, and amongst the articles that I showed you, these two specifically address that again, and both of these two articles here also supported the utility of the Scarbosa criteria, just in case you need even more evidence for the Scarbosa criteria. So let's talk briefly about what a normal left bundle branch block pattern is supposed to look like. We talk about this rule of appropriate discordance with the normal left bundle. What does that mean? It's just a fancy term which essentially means that every time the QRS points upwards, the J point should be below the baseline, and vice versa. When the QRS points downwards, the J point should be above the baseline, so they should be discordant. So take a look. In lead 1, QRS points north, and the result is that the J point is a little bit below the baseline. Isoelectric, that's fine also, but they're in opposite directions. Take a look in lead AVR. QRS points downwards, and so what we notice is that the J point is a little bit above the baseline. That's normal also, and that relationship applies in all 12 leads. In every one of the 12 leads, the QRS complex and the J point should be in opposite directions. If you ever have the QRS complex and the J point in the same direction, you've really got to worry, and that's what Scarbosa talked about. So, going through the Scarbosa criteria, A, B, and C one at a time. Scarbosa A, you'll recall, said if the QRS complex, or rather if the ST segment is elevated in the same direction as the QRS complex, that's an MI. So, take a look at lead AVL, V5, V6. QRS complex points upwards, and the J point is about 1.5 millimeters, or about 1 millimeter above the baseline. Take a look at lead V5 and V6. QRS points upwards, the J point is way above the baseline. QRS points upwards in V6, J points way above the baseline. So ST segment elevation in the same direction. This is a no-brainer. STEMI, this patient's going to the cath lab. That's Scarbosa criteria A. Scarbosa criteria B, Scarbosa described if in leads V1, V2, or V3, where the QRS points downwards, if the ST segment is below the baseline in the same direction, that's bad, more than 90% accuracy. So we'll take a look at these. Lead V1, QRS points downwards, and the J point is in the opposite direction. That's good. We're happy with V1. What about V2? QRS points downwards, J point is isoelectric. That's okay also. Isoelectric is fine. We're happy with lead V2. But lead V3, QRS points downwards, and the J point is in the same direction. It's depressed also. That's bad. And this one lead buys this patient a ticket to the cath lab or a dose of thrombolytics according to the Scarbosa criteria. And by the way, with the Scarbosa criteria, you only need one lead. You don't need to have two contiguous leads to meet Scarbosa criteria. So lead V3 all by itself. What about Scarbosa C? This is the one that has been discovered to be not quite as accurate. A and B, more than 90% accurate. C, maybe about 60% accurate, so not quite as good. But Scarbosa C, remember, QRS complex goes down in V1 and V2. ST segment is elevated. Normally that's good, but it's too much elevated. More than 5 millimeters of ST segment elevation in the opposite direction. That's considered bad. And so this would meet the Scarbosa criteria based on that Scarbosa C. And as I mentioned, there's some articles that have come out that said Scarbosa C is not quite as accurate. And so fewer people are tending to use Scarbosa C. Now, in that article, the Journal of American College of Cardiology article, they pointed out one other possible way of using this excessive discordant ST segment elevation criteria, this Scarbosa C criteria. They referenced a paper by Dr. Stephen Smith, who's an emergency physician at Hennepin, does a lot of great EKG work. And what he had said was that, well, maybe what we ought to do is use the ratio of ST elevation to the size of the S wave, rather than just saying more than 5 millimeters elevation, you're done, rather than just having a definite 5 millimeter number. We should use a ratio. It's just a bit more complicated, but essentially what he said is that if the ST segment elevation is elevated more than 20% of the size of the S wave, then that's an MI. So for example, in this case, the ST segment elevation is 6 millimeters. The size of the S wave is, about 28 millimeters. That's greater than 20%. That means in this one lead that this patient's having an acute MI. And Dr. Smith said that this is more than 95% accurate as well. Unfortunately, that study, is, to my knowledge, hasn't been validated yet, but hopefully it will be, and we will be able to use that eventually as well. So that was just a little bit of a digression into something a little bit more complicated, but very promising. But again, the bottom line, let me just go back for a second to the criteria, the Scarbosa criteria that we should all remember. If somebody has ST elevation greater than a millimeter in the same direction, that's more than 90% accurate. If somebody has ST depression in V1, V2, or V3 of at least a millimeter, that's more than 90% accurate. And then Scarbosa criteria C, not really sure what to do with that just yet. I think perhaps eventually we'll get to using this ratio that I just referred to that Dr. Smith has talked about. So quick recap once again. This is what you've got to know. Who needs to go to the cath lab or get thrombolytics? Somebody has to have concerning symptoms plus one of these 3 EKG abnormalities. They have to have ST segment elevation of at least a millimeter in 2 contiguous leads. We accept that. New or presumed new left bundle in the year 2012. Right now, that's still part of the guidelines. But based on all this literature, a lot of us think that in the next set of guidelines, they're going to significantly downgrade this or just get rid of this. This concept of a new or presumed new left bundle is not really that predictive of an acute MI. So you're going to have to really rely on the patient's symptoms and not the EKG in that particular case. And then most people are really starting to agree with and more and more support's coming out for the Scarbosa criteria A and B. And I think in the next set of guidelines, that's what we're going to be left with. We're going to be left with this, and we're going to be left with that, and we're going to be left with that. Those are going to be the EKG criteria that take somebody to the cath lab. And again, so that Journal of American College of Cardiology article is a really great article, and I've just briefly recapped some of the highlights there. If you have a chance, please read that article, just published within the past week. Make sure your cardiologists know about it also, especially if you ever get hassled for what you're doing with the patient with the left bundle branch block pattern. Show them the Scarbosa criteria. I think some of the cardiology folks out there are still not really on board with the Scarbosa criteria, even though it's in a lot of the guidelines, and now it's in their most high-profile journal. Just show them their literature and tell them that they need to do something with this. And Scarbosa A and B, get those patients to the cath lab. All right, that's it. Hope that was helpful. This was a little bit longer than normal. I apologize for that, but I do hope that was helpful, and I will talk to you next week. Bye for now.